So we'll talk about the disease, the epidemiology, the etiology. We'll do a little bit of clinical presentation, how it's staged on imaging, how we go about approaching the diagnosis of sarcoidosis, and just briefly touch on management. So this disease was initially described in the late 19th century by Joseph Hutchison and Caesar Boeck. It is a systemic disease with granuloma formation, and it's usually in susceptible individuals. It's immune mediated, and it's thought to be targeted by being exposed to specific antigens. And there's a similarity with like molecular mimicry that you see in a lot of autoimmune diseases. It is estimated that approximately 30% of sarcoidosis can be attributed to occupational exposures. And there has been some recent literature review that shows very strong associations between occupational exposures and sarcoidosis. So some of those would be patients that are exposed to silica and silicates. This would be people who work in concrete, are exposed to concrete like slurries, and people who work, for example, in glass manufacturing. There's also was a known increase in the number of diagnoses of sarcoidosis after the World Trade Centers collapsed. This was seen in patients who were living or working around the towers, as well as the first responders, firefighters, and people digging in the rubble itself. And the dust was shown to have crushed concrete, gypsum, and metals. And then people who work in the metal industry and are exposed to specifically titanium are also at increased risk. The AT has the major criteria for diagnosing sarcoidosis. The initial one is characteristic clinical and radiologic presentation for sarcoidosis. Then you have to have evidence of non-caseating granulomas on histology, like on biopsy, and you need to be able to exclude other causes. The prevalence is roughly between 50 to 160 per 100 population, but it varies a lot based on where you live. I think the highest numbers I saw were in Sweden, and then in the United States, the African American population has a pretty high prevalence. It is known to be a disease of younger population. Previously, it was usually just diagnosed in patients 20 to 40 years of age, but now more than half the patients diagnosed are older than 40 years of age. It's classically seen in females about 2 to 1 compared to males. And as I said before, the prevalence in African Americans is higher. It's about threefold higher compared to Caucasians. And the disease tends to be worse in those patients. And also, if you have low income or you live in like a poor socioeconomic status, you tend to have a worse outcome. It's also a disease of non-smokers classically, and it tends to run in families. So if you have a first-degree relative that has the disease and you get the disease, you're also likely to present in actually a very clinical pattern to your relatives. There's also association with the HLA class 2 molecules on chromosome 6. And some of these are associated with the disease, but also there's also alleles that appear to be protective against sarcoidosis. Often it is a self-limited disease, but about a quarter of patients end up having chronic disease and requiring treatment. And the patients that do have chronic disease can have significant morbidity. So going with the etiology, it is an immune-mediated disorder. So you have an exposure to an antigen that can be a number of things. And this is presented to CD4 T lymphocytes by an HLA antigen presenting cells. And this leads to an immune response. You have interferon gammas, you have interleukins, and a lot of cytokines and chemokines that respond to this. This leads to activation of macrophages, which then can evolve into dendritic cells. They can form and fuse multinucleated giant cells, and they also develop a memory for said antigen. So this is just a diagram of the inflammatory process that takes place. And as you can see, you have your antigen presenting cell, your T cells are activated, and then you have this formation of a granuloma that can either resolve or go on to fibrosis. And as you can see, based on our understanding of the inflammatory process, there's a lot of possible treatment options out there for patients. The one that I'll talk about prednisone mostly, but other ones that we deal with within pulmonary would be methotrexate, the azathioprine, and I think infliximab is the other one I'll briefly touch on. There are antifibrotics, as we all know, available. However, they do not seem to be helpful with the fibrosis associated with sarcoidosis. Going into the granuloma itself, it is classically a non-necrotizing granuloma. It has a very tightly packed core that has macrophages and multinucleated giant cells, and it's surrounded by a large number of inflammatory cells and fibroblasts. So with histology, these are just some examples of what it would look like. You do usually need histology to diagnose the disorder. That is not always true, and we'll talk about that in a slide or two. Now, granulomas tend to stay discrete from each other, and you can see there's obvious demarcation between the granulomas on these slides. They tend to distribute along the lymphatic routes and interlobular septae. And the central core, as I said before, it has these multinucleated giant cells. And it's hard to see from here, but there's a few in here that I noticed. I think maybe up in here, there's a few. That might be one here as well. And as I said before, there's usually no necrosis. If there is, it's very minimal, and it's associated with ischemia. And the rim has these layers of immune cells that, if you compare it, for example, to a granuloma that's in hypersensitivity pneumonitis, the layer is a much wider circle of inflammatory cells. As far as clinical presentation, it is a multi-system disease, so it can present in a lot of ways. You can have renal failure with it. You can have kidney stones. People could even have CNS symptoms as though they have a tumor with it. You can have arrhythmias because of heart block, for instance, or syncope. The skeletal lesions could even mimic somebody who has, for say, like metastatic prostate cancer. They can have skin lesions. The one we think about is erythema nodosum. But also you can just develop skin lesions around old scars or tattoos. And then there's this very classic picture with lupus perineo, which is in some of these pictures here, where you have these violaceous skin lesions. They're on the cheeks, they're on the nose, the ears, and the extremities. And this is actually one of those disorders where that can be a clinical diagnosis, and you don't necessarily have to have a biopsy for that. And you can also have involvement with the glands, the parotid, the mandibular, and the lacrimal glands. The systemic symptoms that patients will classically present with would be fatigue, fever, night sweats, and weight loss. Patients will also complain sometimes of exercise intolerance and weakness. This is thought to be because of the systemic inflammation associated with the disease, as well as some other neurologic problems that I don't think I'd touch on in this slideshow, unfortunately. So continuing with clinical presentation, when we're pulmonary, so we're concerned about the lungs. The respiratory symptoms are fairly vague, but one of the most common thing would be a cough, and actually it can be a pretty severe cough with these patients. They'll often complain of dyspnea, and they'll have this chest pain and chest tightness as well. Rarely you'll find some crackles on exam, or you can have wheezing. And if it is severe disease where they already have fibrosis and they are hypoxic, you might see some clubbing. If the patient has a PFT, it will usually show a restricted pattern, but that is not always true. And there's a lot of complications. I'm just going to scooch this up here. Oh, just a minute. Okay. There's a lot of complications that can come with this. Obviously, it's diffuse interstitial disease. You can develop pneumothorax, and then you can develop sarcoid-associated pulmonary hypertension, and that is seen in about 5 to 15% of patients with longstanding sarcoidosis. So these are two other disorders that are very classic presentations, and you don't necessarily have to have a biopsy for them. These both present with bilateral hilar adenopathy on chest imaging. They'll have extrapulmonary symptoms and fevers. And then they have the very classic presentation. So the first one is Lofring syndrome. This is where, again, you have the imaging that shows the hyaluradenopathy. They have these extrapulmonary symptoms, but they also have arthritis. It's usually symmetric in the ankles and knees. I think the ankles are more common. And males can present with just the arthritis and the other symptoms, and you can say this is Lofring syndrome. Females are more likely to present, instead of arthritis, with erythema nodosum. Again, you do not have to biopsy this. You can say this is sarcoidosis and you treat it. But these patients usually just need maybe NSAIDs to help with their discomfort, and this will resolve on its own.
I mean, there is only one situation where you cannot treat empirically for sarcoid and Lofgren syndrome unless you make sure there is not another diagnosis present. Where is it? If you think it's coccygeal.
Sure.
In areas where coccygeal narcosis is very common, if you have this presentation, you have to make sure it's not coccygeal before you give steroid.
Okay.
Because coccygeal can exactly look like this.
Okay.
This is the only situation. I mean, if you are somewhere where coccygeal is not present, this is straightforward sarcoidosis.
Okay.
But if you are in a place where you think it could be coccygeal, you should, because it's the typical presentation: skin rash, arthralgia, and
Okay.
you know,
Yeah.
this is very typical for which is called valley fever. You know.
Valley fever, sure.
Yeah.
Okay. So then there's Hertford syndrome or UVO parotid fever, and this one, patients will again have the same imaging findings and the extrapulmonary symptoms, but they will have uveitis, and then they'll have gland swelling, and it can be in the parotids, the lacrimals, and the submandibular glands. And classically, they will also have a unilateral facial nerve palsy. This is where you see the gallium, like lambda panda sign, where you see it kind of looks like a panda, I guess. If you look, you can see the lacrimal and the parotid and the submandibular glands lighting up there. And then you also see this lambda sign here, and that's the paratracheal and the hyaluradenopathy. Again, this one you don't have to treat. Sometimes they will obtain a biopsy from the lacrimal gland, but you do treat this one with prednisone. So with pulmonary sarcoidosis, scatting came up with stages 1 through 4, and these are still used. It's for chest x-rays. There are other ones out there for CTs and stuff like that, but they're not as well known as this. Every patient who is being evaluated for sarcoidosis should have chest imaging, because in more than 90% of patients, when they do present with sarcoidosis symptoms, they have pulmonary involvement. Classically, you'll have bilateral hyaluradenopathy, and you can also have parenchymal involvement, which can vary in what it looks like. So the four stages for the chest radiographs with scatting is: you have stage 1, which is just the hyaluradenopathy and the parenchyma is preserved. You have stage 2, which is the adenopathy with parenchymal opacities. And then you have stage 3, where you have the parenchyma involvement, but not the hilar involvement. And then you have stage 4, which is the fibrosis part of it. These are not necessarily progressive stages. However, occasionally you will see patients move from stage 2 to stage 3, and patients often stay in the same stage throughout their disease course. So I'm just going to have a few slides looking at the images with the different stages. This one is stage 1. Again, you can see the lungs are clear. You can see this obvious perihilar adenopathy that is present. And these patients with stage 1, they may have mild pulmonary symptoms, but they're not as likely to have systemic symptoms. And these have a pretty good prognosis. Often they will resolve spontaneously within 2 to 5 years. Most patients will do that with this stage.
What's the most common clinical scenario you see stage 1? The very most common clinical scenario where you see them. Pre-employment X-ray.
Yeah, so it's usually an X-ray obtained for other reasons, like
they don't have symptoms.
Yeah.
You get the X-ray for something, and the very most common is the pre-employment X-ray.
Okay, yeah. Stage 1, this is just more imaging of stage 1, showing the adenopathy without any of the pulmonary involvement. Stage 2 is where you actually start seeing some parenchymal involvement. You can have a reticular nodular pattern, or you can have a diffuse parenchymal lung disease pattern. Patients are more likely to have the respiratory symptoms, the cough, the chest tightness, the chest pain, and they also are more likely to have some systemic symptoms as well. So as you can see in this image, you see very obvious bilateral hilar adenopathy, but then you also have some reticular opacities, and it's mostly in the upper lung zones. And if you have a CT of the chest, it can show these nodules, and it will also show opacities. These opacities are usually conglomerations of nodules, and they, again, as I said before, they tend to go along bronchovascular bundles. They like the perilymphatic areas, and you also see them in the subpleural area. This is a very small, I'm sorry, that CT image, it looked a lot better when I was pressing it home. But in this, again, you have the hyaluronopathy, but then you can have these nodules, and then you can have these conglomerations of nodules here, and it can look like a beaded pattern. But it's hard to say because of the size of the image. I'm sorry about that. When we have stage 3, these patients are more symptomatic. They're likely to have respiratory symptoms. They're likely to have systemic symptoms, and they have a low chance of resolving to a normal chest radiograph. The difference here between stage 2 and stage 3 is that you no longer have the hilar involvement, but you do have the parenchymal involvement. Again, it's predominantly upper lobe involvement, but you can see that there's some patchy areas here and maybe here. And again, the hyla is clear in this image. Again, these are kind of small imaging, but you can see that there is no hilar involvement, but you still have nodules, and then you have these conglomerations of the nodules that can look as though it's a beaded pattern along the parabronchial pattern areas. You can maybe see some of it here. I don't know if that's big enough for anyone to even notice, but. And then stage 4, this is where you have fibrosis. You will have mostly perihilar fibrosis, and you can have traction bronchiectasis and fibrotic bands. These individuals are pretty symptomatic, and this does not resolve. This is kind of like the burnout stage. The lungs will not get better from this. And patients who have more fibrosis have more mortality. So more than 20% fibrosis has been shown to have increased mortality within the disease itself. These patients will have exercise limitations. If you have a PFT on them, they'll have a restrictive pattern. They can have symptomatic bronchiectasis. I have some CTs that might actually show up here. So this is a high-resolution CT scan of a patient with sarcoidosis. And again, you can see it's predominantly in the upper lobes, but you see a lot of traction bronchiectasis. You still see some, here, some subpleural nodules like here maybe and here, and then you can actually see that the hyla is displaced superiorly, and that would be because of the fibrosis in those upper lobes. And this is just more imaging, kind of a different appearance, but you can again still see that there is the traction bronchiectasis, the subpleural areas as well, and then maybe this fibrosis in these areas. So with clinical workup, you have to be pretty thorough with these patients and make sure you're not missing another diagnosis. You need to review their clinical information. You usually will have pathology or histologic examination, and then you need to really rule out other reasons why they would have this granulomatous disorder. So you have to be very comprehensive to support your diagnosis and rule other things out. You need to look for other organs that are involved, because often you can find something that is an easier biopsy. And if you can obtain a biopsy from the skin and the lungs, that helps bolster your diagnosis for sarcoidosis. There is this sarcoidosis diagnostic score, and basically it just says that if you have the more organs you can find involved, the more likely it is sarcoidosis. And as I said before, usually more than 90% of patients who present with this disorder have pulmonary involvement. And then other organs that are very commonly involved is the skin, the liver, peripheral lymph nodes, and then the eyes. And as I said, you want to target the easiest place to biopsy that's the least invasive for the procedure. And then when you do have this tissue, you need to make sure it undergoes appropriate staining to rule out other causes for granuloma formation. So obviously you see this patient in clinic, you would want to get a very thorough history, and that includes occupation, travel, pets, like we would do with most interstitial lung disease patients where we're trying to figure out what's going on. And you want to do a very thorough physical examination. Often these patients will have a CBC, a chemistry, liver function test. They'll be tested for HIV, have inflammatory markers done. The serum ACE level is a known marker for sarcoidosis. It isn't really specific unless it's very, very high. So basically, the higher the serum ACE level is, the more likely it is that is sarcoidosis, and less likely other disorders, especially if it's more than 2 times the upper limits of normal. And it is thought to represent the burden of granulomas within your disease. Patients who are treated will have repeat serum ACE levels that are lower. There's this triosidase, which I hadn't heard of before. It's an enzyme that is from activated macrophages. And if you have a high level of this, then you have generally a worse outcome. You can also get a soluble IL-2 receptor. Patients will have hypercalcemia. They'll have hypercalciuria. There's this Kavim test, which is not used, I think, in maybe some research. Kavim, okay. It's used in maybe
It's a German. They've been doing in the old days.
Yeah.
Our attending
Yeah.
media, they love to ask us.
Yeah, okay.
Mr. Book. Germany, sarcoidosis is called book disease,
Oh, okay.
okay, or morbus book, okay. Anyway, the initial days when they started to get to see sarcoidosis in the late 19th century and the early 20th, they were doing this quine test, which is they get an extract from a patient with sarcoidosis,
Mhm.
and they inject it intradermal. If you get a reaction to it, you're positive.
Yeah,
So this is kind of, it's obsolete. I mean,
Yeah.
nobody does it.
Yeah.
And that's, but it's just for the history. And it's called the combine.
fine. I will do it next time. And then obviously you want to make sure your patient is tested for tuberculosis.
Are they positive or negative? Do they react to TB? What's the most likely, if you have somebody with sarcoidosis and TB, what's the likelihood that his PBD test will be positive?
It's unlikely.
It's very unlikely. It's one of the common things or common situations where you may have, if you have TB, the BBD is negative if you have concomitant sarcoidosis. Though it's very rare, but if you have it, it's sarcoidosis, typically you have negative BBD
Mhm.
and positive coin. This is
Okay. Obviously, you have imaging, and we'll talk a little bit more about the imaging in a couple slides. And patients often, if they have respiratory symptoms, they're going to have pulmonary function testing. It is often a restricted pattern with a reduced vital capacity and total lung capacity, and you can see a reduction in the DLCO. Now, if you have a very significant reduction in DLCO, you need to think about sarcoid-associated pulmonary hypertension. Sometimes you'll have patients that get cardiopulmonary function testing. A more common test would be the 6-minute walk test, which is done frequently in this patient. It's just to measure how they're doing functionally with the disease. And if they start having worsening 6-minute walk tests and they're desatting, then again, you also need to think about sarcoidosis associated pulmonary hypertension. Obviously, you want to have an ECG and you want to send them to have a formal eye exam. So classically, you have the chest X-ray, a posterior anterior film. You patients will very often have a high resolution CT scan of the chest. And then patients also may have a PET scan. The 18-fluorodeoxyglucose is commonly used, and it is helpful because it can help identify other lesions that you can biopsy as well. And it actually, the uptake is actually has a linear correlation between the pulmonary function and the forced vital capacity. So if you have a lot of uptake, a lot of active disease, you may have a low forced vital capacity. And as that uptake decreases with repeat scan and the patient's being treated, they may have they'll have improvement in their forced vital capacity. Now, this does not differentiate sarcoidosis from malignancy or infection. They would be positive either way. But there is the 18-methyltyrosine, which pops positive if you have malignancy, but it's negative with sarcoidosis. So that is an option if it's available to you. Then there's the gallium, which I showed with the Lofring syndrome or the Hartford syndrome, where you have you can see these inflammatory foci. It used to be used a lot, actually similar to a PET scan, to look for other areas that would be easy to biopsy. And again, you can have this Greek lambda symbol, but you need to be cognizant that Sjogren's syndrome and lymphoma can also have a similar appearance with the scan. So when we do a bronchoscopy on these patients, and it's usually indicated because the lungs are involved and it's an easy target for us to do, and it's fairly safe now. When you do this, you can obtain a BAL, and you want to get a differential. Classically, it'll be more than 15% lymphocytes. If you're seeing a lot of lymphocytes, like more than 60%, and you see mast cells, your diagnosis should change. You might think hypersensitivity pneumonitis. You also need to think about the fact that TB, fungal infections, lymphoma will also have lymphocyte predominance. You can also get a CD4 to CD8 ratio with your BAL, and I saw 3.5 to 1 or 4 to 1, but classically it is like a higher ratio of CD4 cells to CD8 cells. And if you can get this ratio of more than 4 to 1, if you can have lymphocyte predominance more than 15% and a transbronchial biopsy that shows this non-caseating granulomas, then it's like 100% positive predictive value that this is sarcoidosis and not some other form of interstitial lung disease. Nowadays, though, we see a lot of EBUS done because it's safe and it's actually has a very high yield. And it has a high yield if you have the mediastinal adenopathy and you're suspecting sarcoidosis. The ATS is recommending that you do EBUS more than like the mediastinoscopy that was done previously because it was a very invasive disease. If you have the adenopathy, you can do EBUS, you can do TBNA, and you'll have a pretty good yield. If you do not have the adenopathy, then you want to think about the transbronchial lung biopsy instead, like if you're in stage 3, for example. And then lastly, you would go to VATS, but that does not happen very often because you can normally get a sample elsewhere.
You maybe asked this, but before they use EBUS, they do transbronchial biopsies, and studies have shown that if you do transbronchials plus endobronchial biopsies,
yes,
that will increase your yield significantly, close to 80 to 90%. So usually if someone's suspecting sarcoidosis and they're not doing EBUS or they don't have adenopathy, they do transbronchial biopsies and then they do random just endobronchial biopsies. So they usually go to the first generation carinas and just grab samples from there, from the main carina, and then they send those for samples. So that actually increases your yield significantly because sarcoid is more of a diffuse disease that actually can coat the airway, so you can find sarcoid cells there too.
Absolutely. Yep. So as I said before, your differential has to be very broad with this. You have to be thorough with your examination of these patients to rule out other things that can mimic it. You want to think about infection, cancer, and other just granulomatous disorders. So infections, you want to think about TB, non-TB, mycobacterium, endemic fungal infections. Malignancy, obviously, we're thinking lymphoma. You can have lymphogenic spread. You could think of metastatic or small cell cancer. You also want to think about other parenchymal lung diseases, UIP, POP, hypersensitive pneumonitis, and this is where it's very important to have your good social history to figure out exposures and whatnot. And then you can think about like chronic, as far as other diseases, you can think about chronic fibrosing aspergillosis, or you really want to think about beryllium though, because beryllium can mimic sarcoidosis in many ways, in clinical presentation and on imaging. And patients may not know they've had exposure because it does not take a lot of beryllium exposure to trigger this, but you want to ask about like aerospace, if they worked in aerospace or in sporting goods, electronics, for example. So this is again where it is, and nuclear plants, absolutely, yeah.
What is the test which can define that you have CBD, chronic beryllium disease? There is a test which you do, which you should do if you suspect it. Because if you do the biopsy, it's going to be granulomas. It looks like sarcoid in all aspects. Now, few things are different. In CBD, there is no extrapulmonary manifestation. So if you have eye symptoms or anything, or hypercalcemia or liver enzymes, it's not CBD. So chronic beryllium disease is only lung disease. And only lung, but it looks like sarcoid, lymphadenopathy in the blood bladder. There is a test which we used to do in Ohio. We had like like maybe cohort of 500 patients on at that time when I was doing my fellowship, which is called the lymphocytes transformation disease test. You get a BAL from this patient
Mhm.
and expose this BAL to lymphocytes. If the lymphocytes are sensitized, if you have CBD and exposed to beryllium, these lymphocytes will like proliferate like crazy. If you have no beryllium exposure, they don't.
Oh,
So
okay.
if you have a positive lymphocyte,
You have the just questions they have to
Yeah.
list.
yeah,
Okay.
they like to
Yeah,
ask this question.
we didn't do it now, but they
No,
love to put this question in chest.
It's kind of an old medicine, but
Yeah.
it's
But that's in chest review and chest question.
Okay.
And it's also someone who's working in a nuclear plant too.
That's right. They will mention that.
It's usually nuclear
Okay.
plants but the typical things is this. The symptoms, X-ray, lung-wise, pulmonary, and like thoracic disease is like sarcoid. But if you have hypercalcemia, if you have uveitis, if you have anything, it's not beryllium. Beryllium is just lung. Okay, so the present give you this patient with nothing, and his liver enzyme function is normal, no eye symptoms, blah 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 blah, and he's working in a nuclear plant or whatever. So what test you do is lymphocyte transformation. This is what.
No.
Is there a nuclear plant in Ohio? Right?
Hmm?
Is there a nuclear plant in Ohio? Or
Yeah, we have four.
Yeah, I've seen them driving.
They were kind of all the corner between Toledo and Dearborn. The three of them, and the fourth one is between Toledo and Cleveland.
Hmm.
So we had at least 500 patients.
Yeah.
I mean,
Wow.
big population at that time. The good news is this. This disease is very responsive to steroid. Not only very responsive, it takes you just a load of the steroid to take care of it. So you don't treat like sarcoidosis. You just start them on 10 milligram a day, and like a month later, you go down to 7.5, and then on 5 milligram, you leave them for like 12 months, and that's it.
Mm.
No.
Okay.
So you don't give these high doses. There's
Yeah.
other difference
Yeah.
between it and sarcoidosis.
Okay. Thank you. These are just some algorithms that I don't necessarily think we have to go through them, but again, you have to think about, do you need to get a biopsy in these patients or not? And can you get a biopsy elsewhere? And obviously you need to be thorough about ruling out other causes for their granuloma formation. So treatment is usually based on patients who are symptomatic. So obviously you're not going to treat somebody who's asymptomatic. And also if you have respiratory symptoms and you're being followed by pulmonary and you're having a decline in your pulmonary function, then you would consider treating these patients, obviously. So these patients are classically followed up very closely in clinic, and you want to get imaging to see if they're having changes in their radiographs, and you want to obviously ask them about their symptoms. And as we talked about before, most patients with stage 1 will have remission and they don't require treatment. And when you treat somebody, it's not only to make them patients feel better, but it's also to prevent the irreversible organ damage from fibrosis. And then if you do treat, classically, the first line is steroids. Prednisone is used. And then if these patients require steroids for a long time or they're intolerant to steroids, then you would think about steroid sparing agents. And this would be like methotrexate, and you have to watch these patients for bone marrow suppression. Azathioprine, these patients can have myelodysplastic syndrome, and they can have malignancy. And then the infliximab, which you can have the reactivation of the latent TB, and they can have allergic reactions to this. There's other things, pulmonary rehab, you need to make sure your patient isn't having new oxygen requirements. Patients can undergo lung transplant for pulmonary sarcoidosis. They can also develop sarcoidosis, like granulomas, within their new transplanted lungs. But when they're on immunosuppression from the transplant, it's usually enough to suppress this and treat that. And then, as we said before, the antifibrotics don't seem helpful. So just touching on steroids, because this is what is first line and well understood for sarcoidosis. Usually it's prednisone, and the initial dose is between 20 to 40 milligrams daily. And from what I saw, at least, the initial treatment course is about 6 weeks. And patients who have acute respiratory failure, their dosing can be as high as maybe 80 to 100 milligrams daily. You want to follow these patients closely when you start their therapy, and you want to see if they're improving after the 6 weeks. If they are improving, then you can consider tapering, and it's a slow taper between 4 to 12 weeks. If they're not improving, then you would continue steroids for maybe an additional 6 weeks. From what I saw, at least, the improvement, if you're going to improve with steroids, is within the first month of being on them. You want to give a long treatment course, at least like 6 months, because there is high relapse rates, and the relapse rates can be as high as 70%, and even at 2 years out, it can be as high as 50%. And you want to continue to follow these patients even when they're just on maintenance therapy closely in clinic. Now, steroids have a lot of side effects that we're all aware of. You can have gastritis, you can develop ulcers, they can develop avascular necrosis, they can have myopathies and weight gain and worsening of diabetes. So those are also things that when you're seeing your patient in clinic that you need to go over with them if they're on these chronic steroids. When you follow these patients in clinic, you need to obviously follow their lung function. You would get spirometry, DLCOs, and you would get ambulatory oximetry. I saw every 3 to 4 months. I don't know that I have any sarcoidosis patients that I'm following, so I'm not sure if that's what is normally done here. It is, okay. And then you want to get imaging, whether it's with x-rays or CT. And then the PET scan can also be used to, if you have a patient that has a lot of disease burden, and they had a really nasty looking PET scan, and you're worried that they're going to relapse, you can get a PET scan and see is it a lot better on the PET scan, or is there still a lot of disease process, and are they going to relapse if you take that medication away? Even when your patients are in remission, you're still supposed to follow them. And then you need to obviously be watching for relapse. And relapse would classically present with worsening respiratory symptoms. So their cough will suddenly be getting worse. They'll have worse dyspnea, and their lung function, their forced vital capacity, and their TLC, total lung capacity, may decrease by more than 10%. And they may have chest imaging worsening and maybe reduced gas exchange as well. And when you have a patient that does present with relapse, you don't want to necessarily, you have to think, obviously, this could be a relapse of sarcoidosis, but you don't always want to anchor on that, because they can get infections. Actually, they're on chronic steroids. Often they're likely to get infections. They could have malignancy, all these things. So you need to kind of go back and think, what else could this be outside of just a relapse of sarcoidosis? Yes.
So do you have to do a biopsy, on those patients, and do you have to do another biopsy to confirm sarcoidosis?
Depends how your clinical scenario look like. If your clinical scenario, like if there's no risk for infection, like on top of the steroids, there's no signs or other signs of like infection, patient there's no exposure, you don't have to do repeat biopsy. Okay. If the clinical picture, unfortunately, if you look at the ATS criteria in 2020, so which is the newest, it's only 1 year from the first one, the ERS and ATS, all of the recommendation is very weak evidence.
Yes.
Unfortunately, we don't have a lot of studies has been done in the right way. So that's the most of the recommendation is expert opinion and how is the sarcoidosis center they work. For the follow-up points in here, there's some centers they do eye exam every year. They do the calcium, vitamin D level every 6 months. They do the ACE inhibitor to look for the activation of the disease. No PET scan. There's some people they do screening for cardiac without having symptom, except that the guidelines saying you have to have symptom to do a PET scan for cardiac, but there's no evidence behind anything. So it's mainly your suspicion, how many cases of sarcoidosis you have seen. That's why it's preferable if you have 1 case sarcoidosis and you're not in training and you don't like doing ILD, it's preferable to send this patient to a place that they take care of sarcoidosis, because they see more than what you have seen. Except if you are interested in that topic or something, but it doesn't, you don't have to do we had one that we did biopsy. We had one that she had sarcoidosis.
I don't understand. I had on the floor that was diagnosed several years ago, and she has a couple admission to the hospital, and I think being treated a couple of times. And
depends when the relapse happened. That's very important. She was in remission for 10 years and now she started having.
Very unlikely.
Yeah, it's very unlikely to have a relapse. But
most relapses
during the treatment
within 2 years.
Yeah,
usually.
So if it's after that, I will do re-evaluate, because like, you remember that patient that she left us. So we did that biopsy and it came back like it's still the same thing. Unfortunately, you did the biopsy, what will show? Because he had non-carriering granuloma, is that right? The main thing which is very important in this situation, and you let your pathologist know, in the inflammation and stuff like that, you will see this pathology, like even mainly for the transbronchial pathology, transbronchial biopsy, it's away from the lymphatic system and the blood vessels. It will be more closer to the alveoli that goes with inflammation and infection. And you will not see a lot in sarcoidosis, in pathology, you will not see a lot of inflammatory lymphocyte around away from the granuloma itself.
Right.
So you will see the granuloma in here and sparing the other lymphatic system. But in inflammation, you'll say, hey, I see like a well-formed non-caseatic granuloma, I mean in sarcoidosis with a little bit of necrosis, and there's no surrounding inflammatory cells. In infection or inflammation, it will be the opposite. So that's very helpful in your like.
And this is very important.
Yeah.
Now, the other thing is non-caseating granuloma or sarcoid-like granuloma. I like to call it this way because you don't want to coin sarcoidosis unless you know it is sarcoidosis. These can very much be epiphenomena along with others. You have a lot of malignancies which on the margin of the malignant disease, malignant problem, you may have sarcoid-like granuloma. So if you go in and catch it and you come back with a sarcoid granuloma, it could be just the epiphenomena, something which comes along with what's going on.
Yeah.
Post-radiation, you see it a lot, regardless of what you're radiating for.
Yeah.
Chemotherapy, especially immunotherapies, can induce, you just do the biopsy and you come back with the non-caseatic granuloma. It's not sarcoid, it's a reaction. So this is why you need the sarcoidosis, you need the right clinical situation and setting to diagnose it. Now, what I do with these patients is, one thing is I do regardless of the symptoms yearly, outside of the pulmonary story, is the eye exam. They have symptoms, they don't have symptoms.
And that's what the ATS recommend.
You have to do it yearly. Why I do it? Uveitis can be very bad if they get it. B, most of these patients are on and off on steroid.
Yeah.
You catch the glaucoma early.
And optic neuritis.
And optic neuritis and the blood. So you look for not only for the disease itself, but for what you do.
And that's exactly what they recommend in the guideline, actually. In the new one, not the old one.
Yeah.
Now, the other thing, calcium. Every 6 months. That's what I do regardless. And I like to do urine analysis. Sometimes you get creatinine and calcium every 6 months. I exam yearly if it is normal, yearly. If it's abnormal, it depends on what abnormality, the ophthalmologist will take care of it. In the first 2 years, when the patient, start seeing the patient, I do PFTs every 4 months, 3 times a year. After 2 years, I say, what kind of patient you have, because patients are very much different. Some patients are steady, some patients are like this, some patients improve and then go down. So you want just to get a feeling about your patient in the first 2 years starting knowing. Number 3, patients who are in need of steroid, if you think your patient is going to be on steroid for more than 3 to 4 months, my tendency, I don't know what the guidelines says, because I've been doing this for almost 20 years, so you have your own kind of
right.
in your
And
mind.
that's what they say. It's like it depends on your expert. If you are expert in the field, you continue what you're doing. If it's not against the guideline.
I think this patient's going to be on steroid for more than 3 to 4 months. I start right away immunosuppressive with the steroid from day 1. Right away. I don't wait. Because I know you're going to be stuck with this patient later on.
Yeah.
Infliximab is very, very good drug, but definitely you don't start with it. You have to show a failure or disease progression despite immunosuppressive.
Like what?
The best studies are on methotrexate and azacitidine. I like methotrexate in some patients when the compliance is questionable because it's only once a week. Okay. But take in mind that he has to take folic acid daily. Number 2, the problem with methotrexate, if the patient does not get better in 4 months, you don't know if it's the methotrexate or the sarcoid. And you're stuck sometimes. Sometimes you, I mean, you get into this window with, this is the main reason I mean, people like it, I don't like it. I do azithromycin, it's daily. I know the compliance is questionable here, but at the same time with methotrexate, they have to take once weekly methotrexate, but daily folic acid. So there is something daily they're gonna take anyway, you know?
Yeah.
So I do the azithromycin in order to get out of this trap in 4 months. If the patient is not better, is it not better because the sarcoidosis or the methotrexate? Because this is the typical, actually, the methotrexate lung toxicity happens usually in the first 3 to 4 months. And this is where I want to see if my patient is improving. So this is a trap. You get in if he's not improving. Is it really the sarcoid, or is the now the sarcoid is getting better and you're screwing him with the methotrexate and you go back to the blah blah blah. So this is the main reason I don't like it. But clinical wise, they are as good as each other. Mycophenolate is not one of the good drugs for some reason in sarcoidosis. It's very good in connective tissue disease, interstitial disease, but for sarcoidosis, not well. Infliximab is a very good drug if you the patient's failing, and it's a very good drug in patient when you get sarcoid associated pulmonary hypertension. There is a good outcome and improvement. I mean, you have to start to treat the pulmonary hypertension like pulmonary hypertension, but if you give infliximab along with it, there is a better chance to get better, or to get the patient at least across until he gets the transplant.
Yeah.
Because this is the sarcoid-related pulmonary hypertension is one of the most worst pulmonary hypertension patient you can get. So these patients, once it's there, you start really to plan for like the transplant story, you know.
And the other thing is very important, like I have seen like in some patient that has been transferred from outside hospital, like they treat them with steroid and they start the tapering down very shortly sometimes, which you should not, like you should at least have 4 to 6 weeks to look at the response before you start taper down. And when you taper down, it's not like a taper down over 1 week or 2 weeks or 3. So you will taper down very slowly. Like I had a patient when I was in fellowship, like 6 months that we are tapering down, and when I reach like some, like you will see the patient like symptoms improve, and then when you go like at some level, symptoms will come back, and that's the way how when I it's in 30, he's doing fine. If it's 20, his symptom will come back. That's when I will push the other immunotherapy, and because I know this patient he will stay for some time. Or if like from the first 6 months patient stabilized and I going down, he's doing fine, and I know like 6 weeks. I know within 6 months it will be stop the steroid. That's the time I'll be like, okay, you know what? Let's go back and like stop. But however, in the last, just like now in this conference, as Dr. Lustel said, there is a lot of the expert opinion. They start the steroid from the beginning, and like the methotrexate, if from the first 6 to 8 weeks they see there's no like a good improvement, they will put the
Now the other thing is people who are stable, and I mean, there are many different schools here. If you get a patient on 30, 40 milligrams for 4 weeks, he gets better. And like Mohammed said, you go very slowly down. Your aim is to have him almost off or very close to 5 to 7.5 milligrams in 6 months. This is what you're looking at. Now, at that time, there is a big debate about what you do. If the patient's better and he's now at 6 months on 5 milligrams, what's the next step? The old school says continue the 5 milligrams for 12 more months. So it's 18 months treatment. Okay, so 6 plus 12. Now, I don't know what's right, what's wrong. You know, I look at the patient, and it depends on how I feel. More, there is no either, and you know, this is somebody who may not. I don't know how we take the decision, but sometimes you stop it, and you have to follow anyway. You're following the patient regardless. You know, sometimes you stop it. Sometimes if you don't, what I do the every other day. I go to 5 milligrams every other day for another 6 months, and then either I forget to renew it or the patient forgets. Because you don't know. At this point, you have no idea what is next.
The newest like guideline for treatment, not guideline, the expert opinion guideline for European, not American, for the sarcoidosis, they go with like the 6 months and then try to stop, and the highest will be 1 year. Try to stop and see what's the patient doing. If that dose, it has been at least for the last 3 months. So the thing is,
Mm.
like, if I'm treating and then like I'm going to, like I said, Dr. Lassa said, like we were reached 5 milligram, but I just reached this 5 milligram 2 weeks ago. So I will keep this patient at least 3 months on the same dose, and there's no changes and everything. They try to stop after and see if it happened. Unfortunately, they say if you stop and patient has symptoms, then you can consider, oh, he cannot, he's not responding to, or we need to start the steroid sparing agent. But if you stayed longer, he will not have this relapse. So that's why most of them,
Yeah.
they go 3 to 6 months after, or they start like the alternative way of like, as Dr. Lassa said, of like tapering
It's
down.
it's very actually, it's more, after, you know, the.
I've never had anyone experience-wise that
Yeah.
reached the point of
No,
my
I-
patient are on treatment.
Mhm.
You are a few of them who are on 5 milligram every day. And I know them, I mean, at least here, you know, and I did some here and there all over the place in the world, but I have like a couple of patients here who, since I came in, they have sarcoidosis, which is very steady. And they are still on 5 milligram a day for like 6 years.
Are they on immunosuppressants as well? With the
No, just a steroid.
No,
just
just a
steroid. If
I had a patient, the same thing.
Yeah, if I try
low,
to
yeah.
bring it up to him to stop the steroid, he gets angry.
No, she left one patient from Holzer.
Yeah.
I told her like you have been like literally 4 years on this,
Yes.
no symptom. I told her I will start doing every other day. She says no. Just stop that. And her follow up with me, she didn't come.
No, so the other, I have like couple or 3 patients on this dose. One patient doesn't want even to discuss getting off it. The other one agreed to go to the every other day, and like a week later, he called, his symptoms are bad. He wants to go back to the body.
Do it.
It's very, but this is very tricky. Nobody exactly knows for sure. Once you get them stable, how long you carry on.
So,
Nobody knows. It's, you just take it patient by patient, and by what you think, by you feel, you compare it to, you know, these patients come in phenotypes.
Yeah.
Like, I mean, in sarcoidosis, like any other disease, when you see many patients, you start to categorize this patient. This patient looks like Mr. X. This patient looks like, you have like some kind of few patients in your mind with this disease. You try to see, he looks more like this one, he's gonna need more treatment.
And you might be
looks like
wrong, and
this
you just
one.
like go back and your treatment done.
But in the end,
Yeah.
you are following the patient very closely. It's, I mean,
Yeah.
you can change the decision, you can make it, just reverse it. But it's very, very tough disease to deal with.
You might
It's
have
not-
a patient very difficult, like Mahmoud's patient, like if anything changed, the family will call and like John Biden will call and everyone.
What was Mohammed?
But you said that usually patients need prolonged steroids, which I'm assuming a lot, you would know those patients that you start them on immunosuppression. So if they're on both, do you stop the steroids?
Yeah, definitely. Yeah, when you.
And you keep them on immunosuppression?
Yeah,
or
when
you
you-
stop both eventually? They have, let's say a patient is having appropriate response as you're dropping, their PFTs are better, their imaging are better, there's no relapse.
Immunosuppressive going for how long now?
From the beginning,
Yeah.
let's say from the beginning of diagnosis.
Now what happens with this? Let's assume you start the patient with a steroid and immunosuppressive, and you cut down the steroid. After 6 months, the steroid is off, and the patient is stable. You carry on with the immunosuppressive for at least 3 years. So it's again 1.5 years. This is what I don't know where this comes from, but it seems in sarcoidosis everyone thinks about this 18 month. I have no idea why, but definitely your aim. Once your decision is taken to do an immunosuppressive treatment, your aim is to get off the steroid. This is the main goal number 1. Off steroid within 6 months as much as you can. And once you have him stable, you want treatment for 18 months from A to Z. This is from the start until the end, provided he has been okay after 6 months. In other words, 12 months after being stable, the patient has to be on something before you take it off. This is how I do it. I don't know how others do it. Everybody does it different. To tell you the truth, and everybody has his main idea about it.
And do
So
you
it is,
go with steroid 5 or 10 milligram each time?
What do you mean, like?
Was
when you go
tapering?
down? Tapering. There's no like,
I think they say 5
Yeah.
to 10.
There's no like 1.5, like it's, yeah,
I
it's 5 to 10
in
milligram
general,
every time you
after 1 month of being on 40, if you go down by 5 every 10 days, you are there in 6 months.
So 18
Just do
months.
the calculations.
So 18 months of immunosuppressive from starting steroids or from starting the
No,
immunosuppressive?
from starting the treatment.
Yeah.
The treatment.
Like first day you start treatment.
Yeah. Or in other words, 12 months after the patient's being stable, the steroid and stopping it. So it's 6 months both and 12 months later. But some people do 6, some people do 3 after the, I don't. Let's tell you the truth.
Yeah,
Nobody
no.
knows.
Yeah.
And
So-
everybody does it.
It's totally unfortunately, no, like, evidence.
And even on the investigation, what do you do? Now, I do echocardiogram on everyone
Mm.
who comes in with sarcoidosis, regardless. I don't care. They say don't do it unless they're symptomatic
Mhm.
Yeah.
and do
Yeah.
ECG. I even don't look at their ECG.
Mm.
I even don't look at it. I mean, they do it, but I don't look at it. Because the ECG will, I'm not sure how they got to this, this is interesting. What is the most common cardiac involvement in sarcoidosis is arrhythmia.
Conductive.
It starts with AV block. Rarely, it's usually the block picture. Okay, AV block to grade 1, 2, 3, and then complete, and then sometimes you have this conduction delay, or you will have cardiomyopathy, sarcoid related. These patients will not hide. They have symptoms. I mean, he will come with syncope, he will come with something. So why, I'm not gonna do an ECG and find out AV blocking grade 3, the patient doesn't know of. It's very unlikely. I mean, for me, it doesn't make sense, You cannot have significant degree of a block with no symptoms.
Yeah.
And you want me to do an ECG to catch it?
But the thing, there's some patient that when I read the recommendations, the main reason was like they found that there's some patient, not some patient, a large number of patients that they present with aflutter and AFib.
Right.
So without any other type of block, like
Yeah,
they was
but they
yeah.
are symptomatic.
yeah,
Yeah,
that's right. So
that's
they
what I mean.
yeah they come to the they start their story not with the pulmonary disease.
Yeah, with the cardiac disease.
With the cardiac disease and then with the
This is why, this is exactly what I say.
Yeah.
I mean, it's either block picture or AFib, and they come with sometimes with VFib and sometimes with sudden death. It's bad story. But it's very, very unlikely to have an abnormal EKG on somebody who has no cardiac symptoms, because these symptoms are not to be, they're not hiding. If you have an AFib block, you will have symptoms. If you have AFib flutter, you have symptoms. If you have cardiomyopathy, you will have symptoms. The only thing you will not have symptoms and can hide if you have incipient cardiomyopathy, so rejection fraction of like 45 and doesn't know about it. If they're starting to build up pulmonary hypertension and they don't feel it yet, the ECG will not catch it. This is why I don't care about this. I do an echo and I do at least hear the echo. If the first one is normal, I do the echo along with the eye exam. Because I had few patients, not many, but few with cardiac involvement with the sarcoidosis, they do shit. To tell you the truth. I mean, whatever you do goes wrong with this patient. Whatever you do. It's believe me, you do anything you want, it goes wrong. You look at the book, at the guidelines, you do it according to the guidelines, it goes wrong. You do it according to what you think is going on, it goes wrong. But you send it to cardiologist, it comes back as if you have not seen it.
I have two
The
patients.
pneumonia causing the heart failure.
Send them back. Yeah, I'll be kidding.
It is the cardiac involvement in sarcoidosis is very rough and tough to treat.
And when you don't have make sure when you don't in here in Marshall, we can do cardiac PET.
Yes.
You can do